Okay, welcome to this podcast. My name is Chris Littlewood and I'm a research fellow in the School of Health and Related Research at the University of Sheffield. This is the first in what hopefully will be a series of podcasts where postgraduate students have an opportunity to discuss their research. Today we have Emily Wood with us. Emily is a full-time Clark-funded PhD student, and I'm going to begin by asking Emily to tell us about her background and her journey to the PhD.
Thanks, Chris. I'm a mental health nurse. I came to mental health nursing because of personal and professional interest in mental health issues. And since qualifying as a nurse, I've worked in a lot of different environments, both community nursing, hospital nursing, both in England and in Gibraltar in the Mediterranean. And since coming back to England, I've also been doing a mental health awareness course for the Church of England with some colleagues from mental health chaplaincy. So that's been a really interesting experience. And then a couple of years ago, I got an opportunity to do some research within the mental health research group in health service research in Shah.
Okay.
And so that's taken me away from frontline nursing for a few years. But again, it's been really quite an incredible experience to get to do some research behind the practice that we do as nurses.
Great. Okay, so can we begin by you giving us a brief overview of your current research programme? So what you're doing and maybe a bit more about why?
Yeah, of course. Ultimately, at least 1 in 4 people will get a mental health problem throughout their life. Depression and anxiety are the most common of these, and in fact the World Health Organization estimates that by 2020 depression will be the second most common cause of disability worldwide. Current treatments that we have for depression are at best only helping around 50% of the people who receive them. So medication, cognitive behavioural therapy are really good for some people, but not for everybody. And even for people that they do help, there's quite a high relapse rate. I mean, people are getting ill time and time again. So we're taking a psychotherapy called EMDR, which stands for eye movement desensitisation and reprocessing. It's a talking therapy that has been used for post-traumatic stress disorder quite extensively. And we're taking that and using it with people who've got long-term depression, so people who've been ill several times or for a very long period of time with depression. And we're seeing if there's any potential in EMDR for moving it to using it with a different illness, and to see if there's any justification in further research and taking this forward as another potential treatment.
Okay, so you're applying this in a new context.
Yeah.
So quite a novel line of investigation.
Yeah.
Okay, good. You spoke about depression as being what, the second most common cause, or projected to be the second most common cause of disability. So even though it's so common, it still seems to be under-recognised, poorly understood. Is that your experience at the moment?
Unfortunately, yes. I think mental health problems in their entirety are poorly understood, poorly recognised. There's a major problem with stigma and discrimination against mental health issues and people with mental health problems. I mean, just today there's been a report released jointly by the large mental health charities in this country, along with some of the mental health societies like the Royal College of Psychiatrists, saying that the government is breaking its promise to treat mental health as equal with physical health, that there have been major cuts to mental health services despite their promise that NHS services won't be cut. So we're in a situation where mental health illnesses, mental health problems are just not recognised or treated as well as they should be. I was actually talking to one of the participants in my research a couple of weeks ago, and he was saying he's had to tell the people he works with that he's been doing physiotherapy research because of the attitude that his colleagues have got towards mental health. People are very disparaging, despite the fact that it's so common, and actually if people talked about it more, actually people might know more about it. And unfortunately, it's not just the public who have got this lack of understanding. I was doing a mental health awareness training session for a stroke survivors group, and I was saying, these are the signs of depression, this is what you need to look for. If this is happening to you, this is what you need to do about it, this is the help you can get, all these kind of things. At the end of the group, I asked people if they've got any questions for me, and one of the people said, look, I recognise everything you're saying here, this is me, I think I've got this problem, but I went to my GP, I said all of the things that you've just told us we need to say, and the GP just said to them, yeah, you've had a stroke, of course you're miserable, go away. And
so it's not just general public, it's healthcare professionals as well.
It's just not recognised as the serious problem that it is among even the people who are working in health services, and considering the prevalence, the seriousness that it can lead to, that's something that needs to be changed.
Okay, so it's poorly recognised, but even if it is recognised, from what you said earlier, it sounds like current treatments aren't great. But you're looking at this EMDR, a novel application of EMDR, but from what I understand there's some controversy about this intervention. Can you just tell us a little bit more about that?
Yeah, I think the thing with EMDR is that unlike most talking treatments, there's not actually a lot of talking involved.
Okay.
It uses a fairly unusual technique where the eye movement part of the name comes from. Something called bilateral stimulation, so you're stimulating one side and then the other very quickly. This can either be moving the eyes from side to side or tapping one hand then the other very quickly, so that you're stimulating one side and then the other. Sometimes it's done with people with headphones, so you get a beep in one ear and then a beep in the other. Now, nobody's really sure why that makes a difference.
Well, that was going to be my next question.
Yeah.
What's the link?
We're not 100% sure, and it's one of the things that almost every research into EMDR now tries to incorporate is, can we figure out why this is doing something? What it seems to do is cause a relaxation effect. So at the same time as talking about this unpleasant thing that's happened to you and that's causing you problems, the stimulation then forces a relaxation effect. So possibly that may be how it works. But there's been a lot of question as to actually, whether there's any point to it at all. I think as well, there was another problem that some of the early research, especially for something that is so strange looking, some of the early research was not well done. So a lot of the scientific methodology principles were not adhered to as strictly as perhaps they should have been, which led to quite a lot of people saying, well, you found what you wanted to, but you didn't really do.
Okay, so
it wasn't
just
very
discredited
strict,
right from the start,
which caused it some problems. But I think now we've got some more scientifically rigorous research that is showing that EMDR has some definite potential in certain circumstances, especially with post-traumatic stress disorder. It does appear to be a very good therapy. Why? How it's working, still not sure. But it does seem to be very good. One of the things that the people who don't like EMDR still seem to be saying now is that, well, we can reject EMDR because it's no better than cognitive behavioural therapy. My rejoinder to that would be, that cognitive behavioural therapy is the standard treatment for the standard talking treatment for mental health problems. The implication by being no better than CBT is that it's also no worse than CBT. If EMDR is no worse than the other best treatment, that's worth going with.
Another option for the patient.
It's another option for the patient. No talking treatment is going to be suitable for every single person in every single circumstance. And I'm not sure that anybody is suggesting EMDR is. But for some people, in some circumstances, it is the right treatment. And I don't think it should be rejected just because we're not quite sure how it works yet.
Okay, well that leads me on to my next question about what your research will contribute. But one thing that stands out to me before you answer the contribution question is there an expectation that EMDR might have a mid to long term effect? Or would it suffer the same ways as other therapies and short term and relapse being the norm?
It's a good question. I think it's one of the reasons why further research continues to be necessary, and just dismissing it as we don't understand is unhelpful. EMDR bases its treatment on the fact that your current problems are based on the way you remember disturbing incidents in the past. What it aims to do is to change the way that you remember those distressing incidents so that you are no longer distressed by the thought of the car accident or whatever it was that is now causing you issues. And so that that's not translating into the present. Theoretically, that should mean that it also doesn't affect you moving into the future.
Yeah.
So relapse should be less likely, theoretically, with EMDR than with something like cognitive behavioural therapy, where you are working on your thinking strategies about the present. If you fail to do those thinking strategies, then you may relapse into old ways of thinking, unhelpful ways of thinking. If EMDR truly has changed the way that you think about this distressing incident in the past, then that shouldn't relapse. But we need long-term follow-up studies, and that's the only way we can find out about that. It's not been around for long enough, widely used for long enough, to really be able to say one way or another, yes or no.
Okay, so how is your research feeding into that? What are you looking for it to contribute?
So currently, a lot of clinicians using EMDR, especially in private practice, are saying that EMDR can work for a large number of mental health issues. And theoretically, yes, that certainly would be a conclusion that you could draw from the theory behind EMDR and how it works. The problem with that is that we don't have an evidence base for it. We've got a very good evidence base for EMDR with post-traumatic stress disorder, but not with the other mental health issues. There's a growing evidence base for treating phobias. There's a suggestion for phantom limb syndrome. There's all sorts of different research going on across the world, but until we've actually got that research, we can't say there's an evidence base. So what we've got is clinicians who are working from clinical experience rather than research evidence. So this preliminary work really is to see, is there anything to what clinicians are reporting that actually EMDR can treat depression? If you talk to my EMDR therapy colleagues, they will say, yes, of course it can. I've seen it, I've done it, I know it can. But there's nothing in the literature that agrees with them on that.
Okay.
But that's because no one's done the research, not because they've done the research and found otherwise. So what we're hoping to do is to start to build that evidence base, to have a look are they right? You know, is their one person clinical experience actually backed up by rigorous research? And what we're looking for really, and what we've found so far, is that there is a suggestion, there is potential there. Now, my study hasn't been large enough to say definitively yes or no. What it has shown is that it's got potential and that it's worth doing further research. So it's basically the first step. It's the preliminary. It's the pilot. Is there something worth doing here? Yeah. And what we're discovering is that yes, it is worth doing. It is worth putting the effort in. It is worth putting the funds in to doing a larger scale study.
So is that what you're looking at in terms of your next step post PhD?
I'd like to, if we can get the funding for it. Psychotherapy research is not well funded. As with all things in medicine, a lot of the funding for trials comes from drugs companies. Drugs companies aren't interested in therapy. If talking therapies work, they will do the drugs companies out of their money from the medicines that they need to sell to people. So, you know, getting that money through is difficult. But, you know, the mental health group here in Shar, the new clerk for Yorkshire and Humber, are continuing to look at long-term depression. They're continuing to look at actually the interactions between depression and things like physical illness, how those interact, because they're very closely linked. So there's a lot of really interesting research going on in the wider depression community as well that I'd really like to be interested in moving forward after I finish.
Great. Is there anything else that you want to add? Those are all my questions.
I think the only thing really is that as much as I've enjoyed doing the research, and I think it's been really valuable, and I do want to carry on with research post-PhD, I think coming from a nursing background, the thing that has been difficult doing a full-time PhD is actually I've lost touch with my clients. The reason I'm doing the work in the first place is to try and help people who are struggling with depression, who aren't getting over it. Is there something we can do to help them get past the difficulties that they're having? And I miss working directly with those, so it would be nice to try and combine the two a little bit, although I'm not sure how I'll manage that, but it would be nice, yeah.
That's what you're working towards.
Yeah, definitely.
Great. Well, thank you for your time.
All
I
right.
really appreciate that.
Thank you.
Thanks.